Good morning, everyone. How are you? Hope you're well. Happy Sunday. This morning we're going to talk about intralumbar flexion and neutral spine. Why? Because it's a fundamentally important concept in movement theory. And the situation arose over the weekend where I was doing my post-op ward round. I'd just done a 2-level fusion in a patient, and I was talking to the hospital physio, and I was talking to him about the importance of his movement proficiency after surgery, and it really just dawned on me that this concept abolishes any notion that movement quality was not relevant in spine health. So let's just go back to some fundamental principles. What is a lumbar fusion? So here is a picture of a lumbar fusion. You can see the pedicle screws in place, and you can see that the titanium alloy fixation is holding the spine in a neutral position. So just think for a moment, if we had a patient with a lumbar fusion, and there are many patients with lumbar fusions, which of course stabilise those motion segments through the fixation and ultimately through the fusion. So imagine if a patient with lumbar fusion started to express intralumbar flexion. Now just think for a moment, what would happen to the adjacent segment, the segment above the fusion, or if the fusion was, say, at L3-4, what sort of biomechanical stresses would be below the fusion and above the fusion? Or if it's across L5-S1, what would be happening at the L4-5 segment or the sacroiliac joints? Just think for a moment. It's not that hard, is it? It's fundamental and empirical that there would be a transfer of biomechanical stress to the adjacent segments of the fusion. And so that's what we actually refer to in spinal science, spine pain science and biomechanics, as adjacent segment disease. It's not actually a disease at all. It's just an expression of poor biomechanics after you've had a fusion. So now let's just go back to the idea that you haven't had a lumbar fusion, but you've got accelerated degeneration of the lower lumbar segments, which is very common, or even if it's just normal degeneration. Okay, and so here's an X-ray and an MRI scan of someone who is who has degeneration of their lower lumbar spine. So you can see from those images that accelerated degeneration does naturally restrict motion of the lumbar segments through the degenerative process itself. So in effect, a degenerative process which occurs in everybody is kind of creating its own natural restricted movement. Okay, it's not a fusion per se, but it's still creating its own natural restricted movement. So if we understand that, then the same principle would apply as to the principle that we would be telling our patient who had a lumbar fusion, who has rigid restricted movement, so they're completely fused. So the person who has a degenerative low lumbar spine should receive the same advice. We should be also telling them that if they move their body with excessive intralumbar flexion, they will be creating excessive biomechanical stress on the adjacent segments of their spine. And therefore, biomechanical stress will incite inflammation, activate nociception, and create a further structural deterioration of those adjacent segments, and that will be experienced as back pain, backache, and disability, and a decreased quality of life. So the fundamental message is that movement quality is critically important. It's not only important after a lumbar fusion, but it's also important in lumbar degeneration, which everyone suffers from. And if people don't receive the advice of functional movement proficiency or functional movement therapy as part of their first line education in reversing and curing their back pain, then their symptoms will persist and slowly over time get worse. And so it really annihilates some of the ideas out there from people who claim to be back pain specialists that say that any type of movement is okay, there is no bad movement, and even our own quality care standards and physiotherapy guidelines talk about there being no bad movements, and there you can see it in black and white, proudly published on their website. And you can see other influencers in the social media space trying to promote the fact that it doesn't matter how you bend, even with crazy things like the Jefferson curl. So overall, the information is very poor and empirically and fundamentally wrong. And it really doesn't take too many brain cells to understand these concepts. Usually any patient that I can spend 20 minutes explaining these concepts to understands it. If you've ever got a piece of wire or a spoon and bent it a few times, you'll understand what biomechanical stress is. Within a few bends, the spoon will break in half, and the concepts are fundamental. You don't need a randomised control trial to prove it. On a positive note, here's a little screenshot of the College of GPs actually talking about core stability. So there's many positive things that they say in this little section on their website about back pain. The problem is that even though what they're saying is very, very correct or accurate, there's a specific type of therapist that can actually deliver such outcomes and address the goals that are being described here. And of course, it's not really motor control exercise, it's functional movement therapy, because it's the movement that drives the motor pattern restoration and therefore drives the stability and conditioning of the intersegmental stabilizing muscles. Okay, that's enough for now. Talk to you next time.